Hi, I'm Dave Fernell, the editor of Diagnostic and Interventional Cardiology magazine. I'm here at the University of Colorado, and I have with me to talk about complex PCI, John Messenger. He's the director of the Cardiac Catheterization Labs and the director of Cardiovascular ICU Step-Down Unit. And Kevin Rogers, he's the director of Vascular Medicine at the University of Colorado as well. Thank you very much for joining us. You're about to go into a case that is a CTO. Tell me a little bit about your CTO and your CHIP program.
So I think CHIP program has really been driven by a few things. In particular, I think the development of the heart team, originally maybe intended for TAVR, actually has brought a lot more complex PCI, as well as more collaboration with our transplant doctors. So I think that's really bolstered our CHIP program. And then I think the more facile use of left ventricular support devices has also enabled us to do things we weren't able to do years ago.
This is with Impella or Tandem Heart?
I think both are helpful. Impella tends to be our go-to for left ventricular support during a CHIP case.
Yeah, we also are the only regional cardiac transplant program for about 6 states around us, so we've even done procedures on ECMO, and so we have the whole host of patients transferred in for evaluation for transplant or LVAD support, but oftentimes what they really need is a high-risk indicated percutaneous intervention with LV support, and so that's really become a niche for us.
In the last few years, cath lab volumes have been increasing with more complex cases, and better imaging has enabled, new tools have really enabled these types of procedures. And tell me about the CTOs. These patients in the past would have been relegated to surgery or medication only.
Yeah, I think the CTO patient population in particular is one. Some of these CTOs are last remaining conduit or in the setting of severe LV dysfunction, and previously we really just treated those people medically because we didn't want to hurt them in the cath lab trying to get these CTOs open. And I think really with us being able to have the technology to support the ventricle, be able to do complex intervention with multiple access sites really has increased our ability to get these successfully open and take care of patients that we really previously were underserved as deemed to be too high risk for intervention.
And with your CTOs, you probably use everything in the book with retrograde and antegrade approaches, atherectomy. What are the techniques and tools that you're using?
Yeah. In general, we follow the hybrid algorithm. We try not to spend too much time on one particular method of crossing if it's not working, and often we'll start antegrade, but sometimes we do start retrograde. But definitely that planning process before the procedure helps us limit the duration of the procedure and also limit radiation, which previously was a big detriment in us completing cases successfully.
And these are long cases, so how do you reduce your dose?
I think pre-procedural planning is big. We're fortunate to have equipment that is very low radiation dose, and it's rare, if ever, that we have to stop a procedure these days because of radiation dose. But I think magging out fewer frames per second are also generally good rules to follow when you do a CTO intervention. When
you do your periprocedural workup, do you use CT or do you do a rotational angiography on the table?
We usually go by conventional angiography, although there have been cases where I thought, man, it would be helpful if we had done a routine coronary CT prior to that procedure, but usually it's conventional angiography and several of us discussing the anatomy.
And some of the newer systems that are out there, I know that you can do multiple views in one swing, and you have guidance technologies. And are these helpful with the CTOs?
Yeah, I think they are. We're just now experimenting with some of the new tools that came with the new Philips lab, and some of these involve vessel overlay and the ability to do dynamic road mapping, which we think is going to have a niche in doing CTOs. It certainly needs to be investigated fully, but it's a tool that we're now exploring use of this dynamic road map, particularly if you do dual injection. The algorithms are pretty good at picking up the branch vessels and at least give you a general idea where you're targeting. So I think as we develop these new imaging tools in the cath lab, I think those will help us in these more complicated cases minimize radiation and contrast.
And how about physiology? Do you use FFR or IFR in these procedures?
Usually if it's a CHIP procedure, there's no question about the severity of the lesion. So I think FFR is an important tool for us, particularly in chronic coronary disease. I think we use it less in a CHIP procedure or a CTO because the lesions are unquestionably severe.
In any new reperfusion you get out of it, it's going to be better.
Correct. Yeah. I think certainly having access to IFR really makes the workflow within the cath lab both efficient and economical. The ability to avoid using adenosine for hyperemia if you can is important because it's incredibly expensive. It adds cost to the case, and if you have a clearly abnormal intermediate stenosis with an IFR, catheter, that really saves us and allows us to really move through the case, move on, and even do intervention over that IFR wire. And having it fully integrated within our X-ray system now, with the Philips acquisition of Volcano, has really been a huge plus for us, because we got all those adjunctive tools to integrate. Particularly in stable ischemic heart disease, I think it's an important tool.
And how long are most of your CTO or chip cases on average?
I'd say probably on average 2 hours, plus or minus an hour.
And that could be a lot of imaging time involved in that. So how do you actually reduce the dose? I mean, you had mentioned reducing frame rates, for instance.
Yeah, so I think frame rates, magging out, and being comfortable with bigger fields of view. And then I think we are fortunate, if not spoiled, by our Philips equipment that really just delivers an efficient low-dose radiation.
Yeah, certainly the Clarity has been a game changer. You know, routinely before we had access to this radiation reduction technology with the Clarity labs, really we would have cases routinely in the 3, 4, 5 gray and would be limited by dose. Nowadays we're doing those cases with probably at 1/5 the dose in the newer Clarity labs with the software and hardware processing that Philips has allowed us to do, and it's really
even
changed
with the complexity increasing.
Exactly. Also, all of this now is table-side control, so we actually have access to editing and controlling our own fluoroscopy flavor for the need. We can control the frame rate for fluoroscopy. We can control actually how we do our image processing in terms of whether we capture on 7.5, 15, or 30, and then we can, all that is table side, so we can actively monitor it and control it. Certain tasks require important imaging, and then many tasks can be done with very low fidelity fluoroscopy with very low frame rates. So 3.75 frame rates works well for some tasks, and I think we've gotten used to being adaptive over a case to try to optimize the outcomes.
And can you talk a little bit about the devices used? Guide wires play such an important role with CTOs. What is in your armamentarium, and what do you use as your go-to catheters?
Yeah, so I think the wire escalation, we typically go to Confianza Pro 12 as kind of our last resort. Pilot 200 is really a workhorse crossing wire. I think Fielder XT, if we need to go subintimal and with a plan to re-enter, Fielder XT is our go-to for that purpose. Or if there's maybe a microchannel, we'll go to Fielder XT. Septal crossing, probably Xion is what we go to first, but then also Fielder FC has worked for us crossing septals.
And what's your recommendation to newer operators for CTOs or chip procedures in terms of wire selection? I
think getting comfortable with a handful of wires. You don't have to have 15 in your armamentarium, but maybe be comfortable with 5 of them. I think staying away from the really aggressive wires like Confianza Pro 12, trying to stay away from them early on, particularly if the anatomy is ambiguous at all.
Always trying to know where you are too before you advance equipment over those wires is really important. We see people get balloons and microcatheters ahead of the wires in places that can cause challenges. And I think one of the other things that we've benefited from, and I know I have working with Kevin for many years, is that having multiple operators, particularly if you're starting a program, really is a way to increase your success, because you can have more people focusing on safety around the device, more people focusing on problem solving. And we're in a unique situation in an academic hospital here where we do our CTOs together and a lot of our chip cases with multiple operators, and it just really increases our efficiency, safety, and our success rates, which I think is the ultimate key to getting good outcomes.
And overall here at the University of Colorado Hospital, what are your case volumes for the year?
So we have 3 cath labs here. This year we're going to do about 3,400 cases total. Our PCI volume here in Colorado, with a relatively young state, non-smoking state, is about 400 to 450 coronary interventions, which is pretty good sized for the state, but pretty average. Of that, about 3/4 are acute coronary syndromes, in that we have a high proportion of NSTEMI and STEMI population. So I think over time, we never saw a drop off of PCI volume like many other programs have had in a region where we have over 40 PCI programs for the 6 million people in Colorado. So we have no certificate of need in our state, and as a result we have lots and lots of low volume programs. But we've been very stable over time. We have on-site surgery, and our cardiac surgeons actually refer us many of our hot chip type patients as surgical turndowns, which is pretty important to have indicated PCIs for both chip and CTO. I think we really focus, Kevin spent a lot of time on us ensuring that people really do have medically refractory symptoms, they have evidence of ischemia, and so it isn't just opening chronic total occlusions to open chronic total occlusions, but rather we have targeted endpoints that we're trying to improve. So.
And what do your numbers look like for CTOs and chip procedures over a year?
I think we used 50 Impellas last year, so probably slightly more than that for the total chip procedures, and I think slightly less than that for CTOs, probably between 30 and 40 CTOs last year.
Well, thank you very much for your time.
Thank you.
Thank you.